R.A.T.S in pathology, racing against time for students in pathology. And we shall be continuing with our session on hematology. This particular class shall deal with two topics, both of which are of paramount importance from the examination point of view. A case history. A 53-year-old male with cachexia was suffering from fever and rigor for 3 days. He narrated symptoms of cough with expectoration to his doctor. On examination, his chest revealed areas of dullness on percussion. I hope that you people are able to make a diagnosis or at least suspect one. Where is the pathology? An X-ray was taken and it showed patchy areas of consolidation in both the lungs. His blood count was 98,000 per cubic millimeter. Hemoglobin 8.5 grams. And the peripheral blood showed. So this is the picture. There are shadows in both the lungs, patchy areas of consolidation. And when I see the peripheral blood, this is what is there. There is a marked increase in the neutrophilic series. I hope you people are able to make a diagnosis. What is your diagnosis? Mention the causes, salient features, differential diagnosis in a tabular form. The answer is leukaemoid reaction. The importance of it is given in the enclosure. Even though it is a small topic, it has to have its own subheadings. Think of the subheadings. The subheadings will take us to the answer. Definition. A leukaemoid reaction is a peripheral blood smear mimicking leukemia in a patient not suffering from leukemia. Not suffering from leukemia. You can include that word. So it is a peripheral blood smear or a picture that mimics a leukemia. There are two types. One is a myeloid leukemoid reaction and another lymphoid leukemoid reaction. There are two types. Please do remember. Myeloid leukemoid, lymphoid leukemoid. We shall see what they are. What are the differences between the two pictures on the left and the right? Half a minute time. On the right side, I find that there are mature neutrophils. There is an increase in the number of the neutrophils. The granules are little more prominent. We call them as toxic granules. This can happen in any kind of an infection. So there is an increase. But in this, there is a marked increase in the cells. Here also I find toxic granules. But added to that, there are some cells. Look at this particular cell. It is not a monocyte. It is not a lymphocyte. It is probably a metamyelocyte or a myelocyte. Here again, this is a metamyelocyte. A metamyelocyte, the constrictions are not yet developed for this to become a mature segmented neutrophil. So I find immature cells as well, marked increase in the number, toxic changes as well. So you'll have to concentrate on the count, the maturity, toxic changes, and any other evidence. Now, what is the difference between a leukemoid reaction and a leukemia? There are two contrasting pictures. In this one, again, as I had been mentioning, there is an increase. There is a slight increase in the immature cells as well. So it is a myeloid leukemoid reaction because neutrophils are there, myelocytes are there. This, on the contrary, there is a marked increase in the number of cells. There is a spectrum that I can see. And I find that there are some cells such as the myeloblast or even the promyelocytes. They are all there. Entire complete gamut of the myeloid series is seen. It is a case of a chronic myeloid leukemia. We used to describe it as a college girl pattern. So what are the differences between a leukemoid reaction and a leukemia? This particular tabular column, please by heart. You will have to answer these. What are the clinical features? Blood examination, blast cells, white cell morphology, anemia, bone marrow, autopsy, other findings, lab score. So this is a wonderful list of subheadings that will take us to the differences. So in leukemoid reaction, the clinical condition is reflected. Neutrophilia with toxic granules, etc. And here it is insidious. By chance, we happen to notice or the patient may be developing breathlessness. Blood examination, the leukocyte count is less than 1 lakh. Usually it is around 50,000 to 75,000. Whereas in a leukemia, it is more than 1 lakh per cubic millimeter. Blast cells are very occasional. More than 5% in the case of CML. If it is more than 20%, it is AML. White cell morphology, there will be toxic granules that can be seen. Here there will be immature and atypical cells, blast cells can be seen. Anemia is not significant in leukemoid reaction, whereas it is marked in a leukemia. Bone marrow, leukocytic hyperplasia, here there is increase in immature cells or the blast cells. At autopsy, there can be other changes. For example, a patient dies of myocardial infarction, there will be ECG changes. Tuberculosis, there will be cavity in the lung. There are no such changes in a patient with leukemia but for hepatosplenomegaly. Other investigations such as X-ray, ECG, culture, acid fasting can lead us to the diagnosis. There are no such bad trace over here. Lab score is increased in leukemoid, decreased in a case of CML, but it can get increased in blast crisis. So this particular tabular column, 300% must that you people will have to write. Myeloid leukemia reaction, there is an increase in the leukocytes predominantly mature. There are a few myelocytes and staph forms. Toxic granulation can be present. As I had been mentioning in the first slide, there is a myeloid leukemia reaction, lymphoid leukemia reaction. Lymphoid means lymphocytic series will be there. So myeloid means myelocytic neutrophilic series. Common is bacterial infection, here it is viral infection. Count is around 50,000. Here again it can be 50,000 or slightly less in a case of lymphoid leukemia reaction. Immature cells such as metamyelocytes, myelocytes can be seen, whereas here the immature cells will be the pro-lymphocytes. Sometimes reactive lymphocytes or plasmacytoid cells can be seen in a lymphoid leukemia reaction. This is more common in tuberculosis, viral infection, syphilis, etc. So these are the differences. Very rarely myeloblast will be seen in a case of myeloid leukemia reaction. This tabular column also you people will have to by heart. Compare. So both are cases of leukemia in which I am finding one large cells with vacuolated cytoplasm. In another, there are a couple of cells. One is small with indistinct cytoplasm, another is slightly larger, and there are nucleoli present. Here, nucleoli is not very conspicuous. This is an ALL L2, this is probably L3. Whereas here, it is more of a lymphoid leukemia reaction. I am finding the neutrophils as well, platelets are all normal, so it is more of a lymphoid leukemia reaction, whereas this happens to be a leukemia. I hope you people are able to compare. And here again, see the size of this cell, look at the size of this cell, 4 to 5 times that of the RB. So what are all the diagnostic aids? A complete blood picture, bone marrow picture, lab score, clinical, radiological, therapeutic, ECG, and so on and so forth. We shall be continuing with our classes. The next one happens to be a short topic, but of great importance to us. Burkitt's lymphoma, it's a question for you in medicine. It is a question for you in pathology. Okay. Obviously, it was identified by a person called Burkitt. We shall see his picture down the lane. Burkitt's lymphoma is a type of a non-Hodgkin lymphoma. Lymphoma, there are two types. One is Hodgkin's, the other is non-Hodgkin's. This is a type of non-Hodgkin's lymphoma, more common in African children. And it is commonly present in the region of the mandible or the submandibular nodes, etc. And there is a huge mass that is seen. So much so, it is sometimes described as a jaw tumor. It is caused by Epstein-Barr virus. There are two types of this. One is sporadic, another is non-sporadic or familial. So please see this one. It is of importance to us. And here again, this is a picture taken from the Fred Hutchinson Cancer Research Center. I hope you people are able to make a swelling over here and a jaw tumor. And this is Dennis Burkitt, the person who identified the Burkitt's lymphoma. So the same picture over here. But what is classical over here? It is lymphoma means it involves the lymph node of the spleen, lymphoreticular system. Here I am not able to see the lymphoid follicles, etc. It is diffuse and homogeneous. We call it as effacement of architecture, and it will be punctuated at regular intervals by large cells. So this is called a starry sky pattern. If you look at the sky at night, you will be finding a dark background and then the stars. So that kind of a description is called the starry sky pattern, classical of Burkitt's lymphoma. It is associated with chromosomal translocation. This is chromosome 8, chromosome 14. This is a short arm, this is a centromere over here, this is a long arm. This is another long arm, centromere and the short arm. You find that there will be a translocation from chromosome number 8 to chromosome number 14. You find that a chromosome it gets translocated. So see what happens ultimately, this segment comes and gets attached to it. So you get a chromosome like this with the MYC oncogene. So as a result of which a patient can develop a Burkitt's lymphoma. It is a chromosomal translocation, 8 and 14 long arm, you people will have to mention. And these are the diseases which can be associated with Epstein-Barr virus. See what is happening. One is a Hodgkin's lymphoma. The other is a nasopharyngeal carcinoma, very important. Third one is a Burkitt's lymphoma. And of course, it is associated with many non-neoplastic disorders as well. This is L3. We haven't taken the class on acute lymphoblastic leukemia. We shall be doing it. But then, in this type of leukemia, I am finding large cells. The cytoplasm is abundant and bluish, and it has got vacuoles. This is called ALL-L3. Commonly, it occurs in children around 17 to 18 years of age. So this is called the counterpart of the Burkitt's lymphoma. ALL-L3 is a counterpart of Burkitt's lymphoma. Normally, what happens? The involved node can be several centimeters. It has got a cut potato appearance involving the jaw. Therefore, it is called a jaw tumor, usually associated with an erupting molar tooth. That is why the age is around 18. Growth factors can be implicated and common in African children. So this is something that we people can write very easily. This is ALL-L3, the hematological counterpart of a Burkitt's lymphoma. See this, the same thing is being given over here. Here it's a starry sky, I'm finding pale areas. And this is the hematological counterpart showing large cells, vacuolated cytoplasm. The blood smear, large uniform cells, large nucleus, abundant vacuolated cytoplasm. Nucleoli can be present. Look at these pale areas, they are the nucleoli, generally 1 to 2. Histologically, there is an effacement of architecture. Architecture means it is the relationship of one part of a tissue to another. There is nothing like that. I am not able to find a capsule, I am not able to find the follicle, etc. And there is a starry sky pattern. So I hope you people have followed this class on Burkitt's lymphoma. The treatment for it will be radiotherapy and chemotherapy. And this is the counterpart that we had mentioned. So this is a picture again. I hope you will be able to describe it. Large cell, large nucleus, abundant cytoplasm, vacuolated cytoplasm. A nice quote that I picked up. I had no shoes and complained till I saw a man without legs. Always, no, it is not just for fun that we are reading this. You find that there are patients who are suffering from it, and it is our business to diagnose and treat them. Thank you.